Hello, everyone, and welcome to the Liver Health Foundation's free educational webinar. I am Farah Douglas, President and CEO of the Liver Health Foundation. Today's webinar is about Alagille syndrome. This is a rare disease with significant consequences. In tonight's webinar, we will learn about this disease and how it impacts the lives of liver patients. It is important to note that Alagille syndrome is not just a liver disease. It affects multiple organs in the patient's body, including liver, heart, spine, eyes, kidneys, blood vessels, and has a distinct facial character as well. Alagille syndrome is a multi-system condition that requires lifelong care and solution. Our distinguished experts tonight will offer important information and insights into Alagille syndrome. Liver Health Foundation is proud to host these free educational webinars to raise awareness of liver disease and to educate patients. We are a patient advocacy 501c3 nonprofit organization with the mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, San Gabriel Valley, San Fernando Valley, Riverside, and all other neighboring cities and counties. In tonight's webinar, Dr. Rohit Kohli will offer a comprehensive review of Alagille syndrome through a PowerPoint presentation. At the conclusion of the presentation, we will begin a roundtable discussion with Dr. Kohli, Dr. Robert Venek, and Dr. Rodolfo Silva. During the roundtable discussion, our experts will share their own research and experiences about Alagille syndrome. If you have questions, please use Q&A or chat function and post your questions. Our experts will try to respond to all questions. Now, our disclaimer. Please remember, information given by our experts is not a substitute for advice given by your own physician or healthcare provider. This webinar tonight has been made possible by an educational grant from Epson Pharmaceuticals. We thank Epson for their support of our efforts to help liver patients. I believe we have a video introducing Epson. Thank you. It is my absolute pleasure to welcome back Dr. Kohli, who has been a great supporter of our efforts in raising awareness of liver disease. Dr. Kohli, MBBS, MS, is currently the Chief Division of Gastroenterology, Hepatology, and Nutrition, Associate Director, the Saban Research Institute, Associate Chair in Liver and Intestinal Research at Children's Hospital, Los Angeles, Professor Pediatrics, Clinical Scholar at the Keck School of Medicine, University of Southern California. Dr. Kohli's research work has focused on the pathogenesis of obesity-related liver disease, MASL, Dr. Kohli's lab has specifically investigated the role of bile acid signaling as a mechanism for muscle and regulation of the extreme stage of this disease, which is MASH. He has published more than 160 peer-reviewed articles, including in prestigious scientific journals such as Nature, Nature Reviews, the Journal of Biological Chemistry, Gastroenterology, Hepatology, Journal of Pediatric, and the American Journal of Physiology. Dr. Kohli is the recipient of the 2007 George Ferry Young Investigator Award from the Children's Digestive Health and Nutrition Foundation, a fellowship award from the American Association for the Study of Liver Disease, Takeda Research Innovation Award from the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition Foundation. Dr. Kohli is a member of the American Pediatric Society, National Academy of Medicine, India, and Liver Health Foundation's Medical Advisory Council. We were proud to have acknowledged Dr. Kohli's distinguished and exceptional service to our community and liver patients by offering him Liver Health Foundation's 2022 Healthcare Visionary Award, a recognition well deserved. Dr. Kohli, welcome. Thank you for your support and participation. We are ready and excited to see your presentation.
Thank you so much, Farah, for that very kind introduction. Always humbling to hear about oneself. Also feel old. Let me know if you can see my slide now, full screen.
Yes.
All right. So I'm presenting on Alagille syndrome. This will be a 30,000-foot view, hopefully covering a lot of ground that sets the stage for us to have a Q&A, a robust Q&A at the end. I'd like to give credit and acknowledge the work of Dr. George Yanni, who had a lot of contributions to this slide deck, and to patient care for Alagille syndrome at our institution and elsewhere within the community here in Greater Los Angeles. I do consult for the following companies and have a research grant from the NIH in collaboration with another company as listed here. I'll leave these up for a few seconds. However, I will not be discussing any specific medications today. So Alagille syndrome was first described back in 1969 by Dr. Daniel Alagille in France. It is a genetic disorder, affects multiple systems across our bodies, but it is inherited, being genetic in its inheritance, in an autosomal dominant fashion. The initial diagnosis can be made many different ways. The child can come to a cardiology clinic. We found to have a heart murmur in a general pediatric newborn exam. The child can be seen to be jaundiced in the newborn nursery, and on further workup, diagnosed to have a paucity, a decrease in the normal amount of bile ducts that are seen on a liver biopsy. Hence, there's an issue with plumbing, not having a flow of normal bile going through its liver into the intestines. They also are associated, we'll go in detail, with other system abnormalities, including eye, bone, and so forth, and very characteristic facial features. For something that affects so many different parts of the body, one would assume that there is a fundamental change that occurs to something that is ubiquitous. And that is true. The genes that are impacted are known to function in what is called as angiogenesis, or the production or development of blood vessels. This is rare. We do understand that about 1 in 30,000 children, both boys and girls, are affected. So talking about genes, the specific genes that are known to be associated with having Alagille syndrome are JAG1 and Notch2. The vast majority of individuals affected with Alagille syndrome have a mutation in their JAG1 gene. And a minority, a smaller number, have a mutation in Notch2. So let's talk about a child. And of course, no names are being shared here, But let's talk a little bit more specific about the presentation. So here's a 7-month-old who comes to a pediatric unit, has been persistently jaundiced from birth, now has a large belly and is not gaining weight as you would expect in a newborn who is now 7 months old. The face of that child has a larger than usual forehead, prominence in their ears being placed, a little bit of a depression on the bridge of the nose, and a bulbous nose tip and a triangular overall facies and a pointed chin. The physical exam of the child in terms of the liver and spleen, both are seen to be larger than usual, 6 and 4 centimeters below the right and left costal margins, respectively. And that's about it in terms of the physical and presentation exams. A child undergoes a liver biopsy, and instead of the usual 8 to 10 portal areas that are seen in a normal liver biopsy, only 4 show bile ducts. So about half of the number that is usually expected. And again, this goes back to a plumbing problem wherein the drainage of bile from the liver usually happens through these biliary ducts. If they're not there, you're going to have a backup, and that explains the jaundice, a yellow color of the skin and eyes of this child. Here are some clinical findings now in terms of investigations. The red arrows on the left side of this X-ray radiograph are pointing towards the spine, where there is a central defect along the spinal column, what is also known sometimes as a butterfly vertebrae instead of a continuous a smooth line. You're seeing a deficit within the joint. Here, the middle and the right panels are talking about very specific histological features, which I think might be coming across as well. What we're trying to show is, again, portal tracts not having bile ducts and the presence of abnormal placed bilirubin and bile acid backup or cholestasis. So in a child who has this presentation, what about overall in terms of all children having these presentations? When we look at the total number of children understood to be well-defined with Alagille syndrome, up to 80–90% of them will have liver involvement, and 75% will have bile duct paucity. You can have a very broad spectrum of representative cholestasis, some more, some mild, some severe, including liver tests similarly being affected. Usually the liver is able to function, its normal function of producing proteins and clotting factors. Therefore, it is not an acute liver failure or chronic liver failure situation at the get-go. However, the backup of bilirubin and bile is definitely there. When you look at serum bile acids, they are even a more sensitive marker of obstruction of bile flow than bilirubin. And so sometimes we can pick up serum bile acid elevations without a abnormally high bilirubin. We have seen the more and more literature come out, especially from the hard work of the group in Toronto, Sick Kids, by Dr. Benita Kamat, who has recently moved to the University of Pennsylvania, Children's Hospital of Philadelphia. They put together a group internationally called the GALA Consortium, GALA, which focused on coordinating data such that we're now able to understand even better how many children have, say, ascites or who have variceal hemorrhage and so forth, as listed here. Children usually present early, and as we mentioned, we have the specific physical appearance. The other thing that I have not talked about yet are what are called xanthomas, or lesions, fat deposits on the skin of the child or adult, where you have a collection of cholesterol. One of the things which is interesting is, as I mentioned, bile acids are also part of bile and maybe even a more sensitive marker once there's an obstruction to bile flow as being elevated in the circulation. However, the interesting part is not that. The interesting part is that cholesterol is actually the substrate for the formation of bile acids. And when there is an accumulation of bile acids, because of this obstruction to bile flow, the backup, if we go further, happens not only in the bilirubin and bile acids, but also in the substrate. So now you have excess cholesterol circulating, and that has to be stored somewhere, and these xanthomas or xanthelasmas start to appear. And here's a picture, which is worth 1,000 words, as people say, of the characteristic facies in the top left. Here are some xanthomas that are shown over a child's elbow. This is over the back of a child's legs. And I'm, again, not going into too much detail on the histology, but happy to discuss this in the Q&A section if it's somebody's interest. So we've talked about how the histology changes. The heart is very much affected. This slide summarizes what the affectations are. As I mentioned before, there's a underlying defect in angiogenesis or development of blood vessels because of these genetic mutations. And of course, one of the most important structures that develops in the cardiovascular system is the heart. And herein we see stenosis or poor development or hypoplasia of the pulmonary artery. So a peripheral pulmonic stenosis is the most common finding in about almost 3/4 of all children. Some may even have what's called a tetralogy of Fallot. Alagille's patients who have cardiac involvement have a little bit of a hit against them in terms of survival, as mentioned here. So we have to be even more cognizant of their care, not to say that all children shouldn't be equally paid attention to. When we look at the overall morbidity, mortality, we also have to think about other vascular anomalies outside of the heart. And there's specific ones which include bleeding propensity from having aneurysms, coarctations, and such that up to 30% of patients who have a magnetic resonance angiogram will be found to have vascular anomalies. In terms of how we define this disease, there's kidney findings that are also important to note. Almost 3/4 again of individuals who have Alagilles will have some renal involvement, though there's a little bit of debate in the literature about of that number. When we talk about kidney involvement, it's either kidney dysplasia or renal tubular acidosis. Sometimes vesicourethral reflux or urinary obstruction can be seen as well. Here's more details. Again, I'm not going to go into, but what happens at the microscopic level inside nephrons and tubules inside the kidney. The bone, we mentioned briefly when I showed the X-ray feature of the spine, called the butterfly vertebrae. Here again, about 1/3 to 2/3 of patients will pick up on those kinds of diagnostic vertebral anomalies, spinal anomalies. They did definitely have a higher risk for fractures. We don't understand all of the reasons, but for instance, elevated bilirubin, bile acids, cholestasis does cause a problem with vitamin absorption, specifically fat-soluble vitamins. And vitamin D is a fat-soluble vitamin, which is important, of course, in bone health. Here's a better example than I showed before of the vertebral deficits that I was talking about, the butterfly vertebrae. So in this section here, this is not an X-ray, of course. This is now looking more at a cross-sectional image, or a defect here, right, going through the middle, showing how what we've called before as butterfly vertebrae. We've discussed this picture before. I'm not going to belabor the point, but this is summarizing the facial features as we've talked about before. Hypertelorism is how the eyes are set, and you can see that they're set a little bit deeper and spread out, making the broad forehead even more prominent. This is a less well understood phenomenon in the eye exam, posterior embryotoxon. It is common, but it's also common in individuals who don't have Alagille syndrome. About 20% of children in regular clinical exam will be found to have that. So this is something that can be thought of as an adjunct finding, but individually, maybe we can't use this to make the diagnosis. And here's an example from a ophthalmological exam. This is at the very corner, you can see a sliver of tissue. This is what's called the posterior embryotoxin at the edge of the eyeball. Itching, pruritus definitely goes along with this disorder. You've seen pictures of the xanthomas, especially hands and fingers. Their skin can get being at least exacerbated by that. And because of all these things, when you have itching, we understand the cause and effect poorly, but definitely correlates with the amount of cholestasis or obstruction and jaundice to bile flow in the liver. And add on with the cholesterol deposits, the xanthomas, and add on with the dry skin. All of these three things together lead to very poor quality of life at nighttime, poor sleep patterns, and which then bleeds into daytime, poor attention in the school, and so on and so forth. Here again are the examples both on the hands shown here at the bottom and the legs for having the xanthomas we were talking about. Unfortunately, a feature that we see not too uncommonly in children with Alagilles is that they do not grow to the same extent in height, and also have commensurate poor weight gain. They're usually closer to the bottom half of the percentile score. And again, we do not completely understand why this happens. Developmentally, there is growing concern and closer monitoring is being done through studies, but we're not sure that there's a large proportion of these children that are affected with deficits, but some do require special education and support, whether this is coming from poor quality of life issues that we just discussed or nutrition, chronic disease itself being overall requiring time and effort to be taken care of. There are many different constructs that we could think of, but do not have proof as to why this significant minority of children with Alagilles have needs for special education. The diagnosis, you have to put all this together. You need physicians such as Dr. Silva, Dr. Venick, who we'll be talking to in a little bit, coming in with a high index of suspicion when a child with either a heart murmur or a prolonged jaundice is presented to their clinic. Initially, you will do standard routine liver chemistries, maybe an abdominal ultrasound or an echo of the heart, kidney ultrasound, kidney function tests, x-rays of the spine, the eye exam, everything we just talked about. But the diagnosis is, of course, made on genetic testing and liver biopsy. The management, very high level again, is based on medical management for the complaints to date. And of course, we'll briefly touch on more significant surgical interventions such as cardiac and liver transplantation. So for nutrition, we want to give more calories. We talk about medium chain triglycerides or MCT, which can give more calories, not needing micelle formation with bile acids. So if there's an obstruction to bile flow, we need for large chain fats, long chain fats rather, you need bile acids to collaborate what we call form micelles so that they can be absorbed into the body for the body to use them through the intestine. However, given the obstruction to bile flow, we have a poor or decreased ability to absorb fats and fat-soluble vitamins. That is where medium chain triglycerides, smaller length of the fat molecules, are easier to absorb, and we encourage that usage. Sometimes we have to use catheters and so forth, and of course, I have to give higher doses of fat-soluble vitamins to make up for the poor absorption. This is where things have changed. There's a long list of things that have been tried for the pruritus up at the top listed, including many different things that we've used when I was in training. But today, there's been a sea change. We have ileal bile acid transport, where the bile acids are taken up in the last part of the small intestine or ileum, or IBAT inhibitors. These class of drugs have been now on the market for a few years, and when used, they cut down on the jaundice, they cut down on the itching, and now there's even more data coming out that there's benefits to growth. So a lot of improvement has been seen with these drugs, and monitoring continues as to both the pluses and minuses of these new IBAT inhibitors. Liver transplantation is also sometimes necessary to be offered and discussed with positive and pros and cons openly with the families. When children have severe pruritus prior to the IBAT inhibitors specifically, or they have synthetic dysfunction of the liver or complications of chronic liver disease, which can now still occur. And sometimes both the kidney and the liver have to be changed. Very, very rarely with the cardiac manifestations we discussed, a heart liver transplant is also indicated. But thankfully, that is not for the majority of children or adults with Alagille syndrome. And I will stop here so that we can have and enjoy conversation with all of the providers that are present here today. Thank you so much for the opportunity.
Thank you so much, Dr. Kohli. Great presentation, great information. This is a disease that unfortunately we hear a lot about, but it's not too well known because it's a rare disease again. But this was a wonderfully detailed presentation, and we hope that people get enough information from your presentation and now during our roundtable conversation. In this part of the webinar, we do a roundtable conversation with our guest experts who will talk about Alagille syndrome. And we have received some questions that our experts are going to try to respond to. And if you have questions, please add it to Q&A tab so we can answer them. It is now my pleasure to welcome Dr. Robert Benek to the webinar. Dr. Robert S. Benek is Professor of Pediatrics and Surgery, David Geffen School of Medicine, Director of Pediatric Liver and Intestinal Transplantation Services, Mattel Children's Hospital, UCLA. Dr. Benek attended medical school at the University of Southern California, USC, and completed his residency and fellowship at the University of California, Los Angeles, UCLA, where he pursued a Master of Science in Clinical Research. He has been a faculty member at UCLA since 2006. Dr. Benek is the chair of the Scientific Committee for the Intestinal Rehabilitation and Transplant Association. He is active in many professional societies in the pediatric, gastroenterology, hepatology, nutrition, and transplant communities. He has authored over 75 peer-reviewed publications, and his teaching skills have been recognized by many of the trainees he has mentored over the years. His clinical skills have also been recognized as a Southern California super doctor. Dr. Benek's clinical and translational research in intestinal failure has focused on nutritional outcomes and the role of omega-3 fatty acids in intestinal failure-associated liver disease. His interests are in the area of intestine transplant, liver transplant, Wilson's disease, liver disease, biliary atresia, and I knew how to say hyperbilirubinemia. Dr. Benek, welcome. Thank you for your participation and welcome to our webinar. Now I'm happy to introduce and welcome Dr. Rodolfo Silva. Dr. Silva is Director of Pediatric Hepatology, Assistant Professor of Pediatrics, Division of Pediatric Gastroenterology, Hepatology, and Nutrition, Loma Linda University School of Medicine. Dr. Silva completed his Pediatric Gastroenterology Fellowship at UCLA. He's currently the medical director of pediatric hepatology at Loma Linda University Children's Hospital, where he manages a variety of liver disease. During his time at Loma Linda University Children's Hospital, he has helped create a multidisciplinary Fontaine Clinic to provide more comprehensive care to his patients. He's also the primary hepatologist for Loma Linda University Children's Hospital's Cystic Fibrosis Center. Research interests include immune-mediated liver disease. Thank you, Dr. Silva, for your participation and welcome. To start the roundtable discussion, please all doctors turn on your cameras. I would like to ask a question that was repeated several times. What is malabsorption and how it is related to LAGS? Are there any cure for it, or is liver transplantation really the only and final remedy? Dr. Kohli, would you want to start, please?
Happy to, but I think maybe Dr. Venick, with his expertise in intestinal transplant, might want to take this one first.
Sure, it's an excellent question, and there's a number of reasons I think when we look at Alagille's children, as Dr. Coley eloquently ran us through, that we can see challenges with growth and weight gain. Sometimes it's challenges with taking in enough calories in a child who has quite a bit of pruritus and itching and has increased energy needs. And then as the question referred to, sometimes there's a component of not being able to absorb enough of the calories that a child takes in. And that can be related to a topic that Dr. Coley touched on, which is when one's serum bilirubin levels are high and we're not seeing enough excretion of bile and bile acids into the gastrointestinal tract, then in particular, calories that are rich in lipid, which if you think for infants and young children, a lot of their calories do need to come from fat. So they may have real challenges with diarrhea or malabsorption, in particular of those components. It's also not uncommon, I'm sure, for all of us, the Alagille's children that we care for, to be on multiple medications, and that can contribute or exacerbate diarrhea and absorptive issues as well.
Yeah, so I completely agree with you. So when in the spirit of roundtable, maybe Dr. Silva, do you want to think about what is in your mind when a patient comes to you and says, and you're telling them they have malabsorption, what is the definition of malabsorption you're thinking when you're sharing that with them?
Yes, when I'm sharing the concept of malabsorption, I'm thinking, these patients are having trouble, absorbing certain nutrients in order, be able to grow the way that we expect them to. So in evaluating that, usually that involves, getting height and weight, plotting them on their growth curves, seeing where they lie in those categories. Also getting laboratories, looking for various vitamin deficiencies. So the main ones that we prioritize are the fat soluble vitamins. So that's A, D, E, and K. So those are ones that we know they're particularly prone to being deficient in, and that we preemptively actually supplement to prevent those the malabsorption from causing those deficiencies.
Thank you. Para?
Yes, Dr. Kohli, you talked about aneurysm and bleeding. This is something that is very crucial and very dangerous. What is the sign of it for parents to know something like that is happening to their child?
Yeah, it's not a sign you'd want to wait for. So a lot of times what we talk about is monitoring or evaluation with radiological tests such as MRAs, MRIs ahead of time. And there is not a lot of consensus, and I'd love to hear my colleagues' opinion on this. For instance, there's an entity called Moya syndrome, which happens to be within the brain, a malformation, aneurysm in the blood vessels. Not everyone has it who has Alagille syndrome, but on large studies, when people have looked at the presence of it, the question becomes taking that data from large studies to an individual child who's sitting in your clinic, even if they have evidence of that on a MRA that was done preventively as a routine test, what are we going to do with that information? Are we going to act on it? So I'd love to hear what the other experts on the panel think and do in that conundrum.
Thanks, Dr. Coley. Yeah, it is, as you mentioned, not something that we want to wait for. I think we probably have consensus when we have a young child that we are listing for liver transplantation. We can get into that a little bit later. And we know that the child will be undergoing, will be going to the operating room. And the same can be true with our cardiac colleagues. If a child is undergoing tetralogy of Fallot repair, and sometimes even stenting for the pulmonary artery narrowing, oftentimes teams will go ahead and get the MRI that Dr. Coley referred to, an MR angiogram that can show us a very detailed view of the vessels in the head and neck. And then many times we will repeat these. Our standard interval really depends on what the initial finding was or wasn't, if there were any concerns. But typically every 5 to 10 years, has been our practice to repeat these and to make sure, because just because they're not seen in infancy, they can be seen later in childhood or adulthood.
Dr. Silva?
Yes, so at Loma Linda, we're not a pediatric liver transplant center. So oftentimes these discussions are more deferred to CHLA or UCLA, where when the time comes for, either, liver transplantation or, a big cardiac surgery, that's likely when those evaluations would happen, just like Dr. Vanek mentioned. When I, coming from a tertiary center instead of a quaternary center, oftentimes, the way that I, come into this issue is, with their initial evaluation. So, in an infant, we may do a head ultrasound. It's not very specific and more just kind of rules out that there's any evidence of, any kind of bleed that's happening at that point. But typically I defer more advanced studies to, prior to those big surgeries.
Yeah,
No.
I think to summarize, I think it's a very risk benefit an individual specific situation based discussion, which is where we would end up. I think trying to draw the line because these interventions for these findings are also not small in terms of their risks.
I'm going to wrap two questions in one. What percentage of Alagille syndrome patients will need transplantation? And the other question is, what percentage of these patients actually get this disease that is passed down to them from their parents?
So it's a moving target with Alagille syndrome. Historically, the most common reason for liver transplantation had been recalcitrant cholestatic pruritus. It was definitely bone issues and chronic liver disease and other conditions were part of the spectrum, but a lot of times it was the debilitating itching, which seems on the surface, no pun intended, to be a superficial issue, but really for these children, it was to be seen to be believed. And today with the IBAT inhibitors, that percentage that used to be 20, 30%, depending on which paper we read, is changing. Love to hear everybody's thoughts.
Yeah, thanks,
Dr.
Dr. Coley.
Yes.
I think, yeah, traditionally, it's been around 15 to 30% in the literature. Many of us, I think, have a number of patients who benefited from the newer generation of medication. And as you heard, if pruritus was one of the main driving factors, we now have medical therapy that is quite effective for many children. We all have cared for kids with Alagilles that actually have minimal liver involvement, and we also have cared for kids with Alagilles that have very aggressive liver involvement beyond just, and the pruritus can be life-altering, but also there are children who can develop biliary cirrhosis even in their first year of life. In terms of, I think, the second question that Ms. Douglas asked, if a parent has Alagille syndrome, their child has a 50% chance of sort of inheriting that mutation from the parent.
Dr. Silva?
Yes, I agree with all the points that Dr. Bennett and Dr. Coley made. Those are pretty much the numbers I'm familiar with as well.
So, Dr. Coley, you talked about the smallness of the children who have Alagille the syndrome, that their growth is less than other kids. Does that stay all their life with them? So when they're adults, they're still smaller adults, or with medication and diet, will that go away, and do they grow to be a normal size?
It's a great question, and for parents, especially who have recently diagnosed children recently diagnosed with Alagille syndrome, it might be a question top of mind. I go back in my mind to when I was in training in Chicago, and one of my faculty at Northwestern, she was very interested, still is. She's practicing in a different East Coast hospital now. Very passionate about Alagille syndrome and the children, their families, and she hosted on a weekend during summer when Chicago's nice. She hosted a Alagille's Day. And at that time, it was my personal first exposure to so many children with Alagille syndrome in one spot. And I could see when we read in textbooks, it's one thing. Dr. Venick spoke to the fact that there is variability in presentation. And it goes back to the variable penetrance. There's a genetic term for how a similar genetic mutation affects different people differently. But I could see it. There were children who were short stature, there were children who were tall, there were children who had a lot of xanthomas, there were adults who had signs you could see in terms of poor growth over the years, and everything in between. So suffice it to say, back then, back in the early 2000s, sorry to give my age away, but back in the early 2000s, when we had limited interventions available, we saw the full spectrum of the disease. If you called 35 families who had children or adults with Alagille syndrome into an auditorium. Today, the hope is different. As I mentioned in the short presentation, there is early data that these IBAT inhibitors actually may help growth. Therefore, the future of these children may not purely depend on the chance, the luck of variable penetrance, but we may have a way to overcome the malabsorption, the first question you asked, because we now will have more bile acids to form micelles, and therefore to have better fat-soluble vitamin absorption, and then hopefully overall better nutrition and growth. Again, I'll stop here. Sorry for that historical anecdote. note.
Dr. Vanek?
Yeah, I think that was really thorough. I think I would just add that, we've all had the privilege of caring for children and sometimes siblings with Alagilles, and it's not uncommon to see as a cohort or a group of patients in general for the height as an adult or a young adult to be in general shorter than the population. But having said that, we all probably cared for Alagille's patients that are quite tall. And so the variability, as Dr. Coley referred to, the phenotype, can be quite variable with Alagille syndrome, affecting different organs in some children and not in their siblings, and height as well.
Dr. Silva?
Yes, yes, I would like to echo the points of, Dr. Coley and Dr. Vanek. It's very much a spectrum. And, one aspect that really influences the growth as well is, how are each individual organs doing? As you can imagine, someone who's very, very ill, from the cardiac standpoint may need more calories in order to, achieve the growth that would be expected otherwise. Same with the liver disease. And you combine those two together, you can imagine that child individually as a person may have a lot more difficulties growing. So, I think it's something where you may have patients that have very mild disease, and, maybe for them, they would have achieved the normal growth that would have been expected based off their parental heights. Whereas may have children that are very sick, and, because they are chronically, ill from those organ systems, they may not achieve the growth that would have been expected. But I think one important point is that, because it is a spectrum, there's not one universal expectation. And, for many conditions outside of Alagille syndrome, there are individualized growth curves that go along with those conditions, but that's not necessarily true with Alagille syndrome. Again, because it is a wide variation and it is a spectrum.
Thank you. So let's talk about the accuracy of genetic testing. We had some questions about that. There are parents who don't have the genes, they never knew they had the genes, but their children have Alagille syndrome. So the question is, can Alagille syndrome be prevented, even if they can detect the gene, the defective gene, early on? Is there anything that our medicine or doctors can do to stop it, to prevent it from happening? Dr.
And
Dr.
for,
Cody.
yeah.
I think there may be some technical difficulties for Dr. Coley.
Yes, I lost him.
Internet related. I'll step in, and Dr. Silva has great insight into this. But while we said there's a good number of children with Alagille syndrome who inherit the disease from one of their parents, somewhere around 50 up to 70% of Alagille's cases may be what we refer to as de novo mutations, meaning that mom or dad does not have Alagille's. And in these cases, I think that's an important point. It's nothing that a parent did or didn't do or could have prevented. For our families with Alagille's, when a parent's known to have Alagille's themselves, there are genetic counselors, and there are maternal fetal specialists that we have worked with, and some families choose to see those specialists and others do not, and that's certainly understood and an individual decision. There is the capability in this modern era to sort of work with one of those specialists, though, for future pregnancies if a family is looking to try to avoid a another case of Alagille in the family. Dr.
Mhm.
Silva, would anything to add on that?
Yeah, so genetic testing is very good. But, as Dr. Vanek mentioned, you may, have a child that has Alagille syndrome where, neither the father or the mother carry, a copy of the gene that's associated with it. Um, so it's really individualized how you approach that. I've had families where, they want to know if they're the carrier, just so they could, mentally prepare if they do have, if they have a child who was very sick with Alagille syndrome and they're planning on having other children, they sometimes want to be prepared,
Mhm.
mentally, emotionally, and, in every other way that you can imagine, by knowing that beforehand.
How accurate is this genetic test?
I mean, if the parents have the mutation, the testing is very good. You're mainly looking at two genes, the JAG1 gene and also the Notch2 gene. Those are the ones that are associated with Alagille syndrome. So because it is, you're essentially, getting the genetic makeup of those genes, you can tell if you have one of those mutated copies that are associated with Alagille syndrome. For de novo ones, you wouldn't be able to pick that up from the parents. So brand new ones that arise just in the child, those ones would not necessarily be picked up in the parents.
Mhm.
There, can you hear me? Sorry, I'm having trouble with my
Yes.
internet.
No, welcome back.
There are unfortunately some uh, kind of limitations to genetic testing for it's getting better over the years.
No, we lost you. Dr. Vanek, do you want to jump in while we're waiting for Dr. Coley?
I would just maybe add that I think where Dr. Coley was perhaps going is that most geneticists, when they have a child that may have some of the clinical features, and we really suspect Alagille's, or we have a liver biopsy that's consistent with it, there are non-syndromic cases, and there may be some other genes in play. Dr. Silva covered the two genes that we think make up the vast majority of Alagille's cases. But we also have non-syndromic paucity of bile ducts, and some of those cases can mimic Alagille's as well.
In the way we read it and understood that Alagille syndrome really impacts a lot of organs within your body. So which one is the one that causes the most trouble? Is that liver? And after liver, is that the heart? And do they do, I think Dr. Coley mentioned something about doing simultaneous heart and liver transplanted, or kidney and liver transplantation. How often is it something normal that happens a lot?
Good question. I think Dr. Coley alluded to the prevalence in children who about 3 out of 4 kids with Alagille's have liver involvement, and that number may be higher depending on how you sort of set the criteria. Sometimes it's quite mild in terms of how that manifests for a child. So I guess in terms of prevalence, liver and heart are definitely leading the list. But again, both organs or how it presents in a child can be quite different. I guess that's a theme that we're hearing tonight. Some of the kids require cardiac surgeries early on, and that may be their most involved, part of their condition. And others, it's very mild. The prevalence of having heart involvement is real, and sometimes can be the major topic of discussion in caring for these children. The heart liver transplants, and we do more and more of those, it seems, in 2025 than we were doing 20 years ago or so. I have to say, for the Alagille's population, the percentage of patients that go on to require heart liver simultaneous transplant is actually quite small, in a good way. We have other conditions that make up a larger percentage of that. It has been done. It's a major requires, major teams and communications that all the institutions tonight have and so forth. But that's a big deal. I think that the prevalence of kidney insufficiency, certainly in young adulthood, is something that we're all in tune with. And for our patients that require transplants, folks like Dr. Yanni at CHLA, Dr. McDermott here take special protocols and precautions to individualize their immunosuppression and make certain that we're taking good care of the kids' kidneys, and that they're seeing kidney specialists and so forth.
And Dr. Silva, I know you don't do transplant at LLU, but now let's ask you a question about, can you describe to parents who are worried about their kids with Alagille syndrome, what is a normal day for an Alagille syndrome kid at the school, personal life? And then how is it that some of them have liver transplant or other transplants? Some of them just live with Alagille syndrome and are as adults now. What are they like, their lives? What are the things that they cannot do, and what things they can do?
Yeah, so I think it really goes back to the question of what does that individual child's phenotype look like? What organs are impacted, how severely? Obviously, for a child that's, very mild, meaning that, not very significant cholestasis, maybe no heart disease at all, they could live very normal lives, where, they may have, one or two medications, perhaps, but they do everything else that any other child can do. That said, when you have a child that, may have heart and liver involvement and they're pretty severe, that may be where it's a little bit more challenging, and you're really working on the quality of life issues, trying to get that good nutrition in there. So, for parents, that might be when they're younger, that's definitely more taxing in terms of trying to make sure that they get enough calories to be able to grow. And giving them, their fat soluble vitamins, giving them any other supplemental vitamins they may need. And as Dr. Coley and Dr. Vinnick, mentioned, one of the big things that, in the not so distant past, that was is something that pushed people towards transplant, was really that, cholestatic pruritus, the itchiness that comes from the cholestasis from the liver. But there are much better medications now that seem to have really changed the trajectory of that. So, you may have a child who, if this medication wasn't around, their quality of life would actually be pretty poor because they have, intractable itchiness, that keeps them from sleeping, and then they scratch it, it may become infected, it may become painful. So now you have medications that more effectively can, reduce the itchiness that these children feel. So, they may be able to do a lot more things that they may have not been able to do if they didn't have these type of medications around.
And I understand Dr. Coley is back. So we're talking, Dr. Coley, about the normal life of a child with Alagille syndrome, how they are at school, at home, what are the limitations. So I think one of the limitations will be doing sports.
That's and I apologize for my connection issues now. I'm standing underneath the cell phone tower with one hand, so I'm kidding. No, I'm still at home. No, talking about sports is a very touchy subject with which any child who wants to participate, wants to be part of the team. And when we talk about children who have cholestasis for any reason, including Alagille syndrome, and have vitamin deficiencies, specifically those that are important, those vitamins that are critical for bone health, then we're looking at increased risk of fractures. And when you are talking about contact sports, especially with a child who has a large spleen, which is usually on the left side of the body and is tucked under in normal individuals, the rib cage, this enlarged spleen now comes out from under the rib cage and is exposed in the open kind of not protected by the ribs area of the abdomen. So you add that risk of bleeding into the spleen if there's an injury, what we call a splenic fracture, which is possible. With the risk of fractures with the brittle bones, it becomes very difficult conversation sometimes in the clinic. And these children are normal kids with normal needs and normal questions about participation in activities. So yes, unfortunately, these are very difficult conversations.
Mhm. Dr. Bennett, did you want to add something?
I think both Dr. Silva and Dr. Coley summarized really nicely. I think with regards to the health-related quality of life, I think in the last 5 years or so, a lot of light's been shown on the importance of this and the impact that the cholestatic pruritus can have. I applaud actually a lot of our partners, you know, in pharma, Ipsen and Mirum, both for helping with patient advocacy and shining light on these topics. And I think they've in turn got healthcare professionals tuned in to routinely asking about school performance and older kids, sleep and so forth, because these are the front and center for patients and families, right?
Right, right. Well, thank you so much. This is all the time we had for questions. There are a lot more questions, so we will probably revisit this subject in the future because that's really a very important disease and has huge consequences on everybody, not just the person who has it, the child, but also the parents and the siblings and everybody else. So I want to thank you. We are thankful for our excellent guests who agreed to support this webinar. I need to let our audience know that our doctors are not receiving any kind of stipends for what they are doing. They are doing these seminars, these webinars as a volunteer work because they care. They care about their patients, they care about you, and they are supporting our efforts to get the news out to everybody. So my real appreciation to all of our doctors for the kindness and compassion. You are wonderful. Thank you, Dr. Coley, for a fantastic presentation and the information you shared with us. Thank you for also being a constant, wonderful friend to Liver Health Foundation.
Thank you, Farah. And it was great talking with Dr. Silva and Dr. Vanek.
Yes, I'm very happy we had experts that knew about the disease. Thank you, Dr. Vanek. This was your first webinar participation, and we are greatly appreciate your kindness and looking forward to working with you more closely. Thank you, Dr. Silva. Welcome to our educational webinar. We hope to have your participation in our future webinars as well. We thank Epson. We apologize for the sound, but we will add that when the video is presented, and we will show that their video at the end as well. Liver Health Foundation will host an educational webinar on primary biliary cholangitis, or PBC, and primary sclerosing cholangitis, PSC, on September 10th. These are two rare genetic liver diseases that impact women and men. The speakers for our PBC and PSC webinars are Dr. Ayub from Cedars-Sinai, Dr. Khan from USC Keck, and Dr. Lee from Hoag Digestive Health Institute. We appreciate Mirum and Epson Pharmaceuticals for supporting our efforts. Please don't forget to register to walk with us on September 20th at our annual Walk for Your Liver, Los Angeles in Santa Monica. This walk will brings the LA liver community together. We will hear from liver patients, physicians, and we'll walk to Santa Monica Pier and back. And it's a beautiful setting. We will have breakfast for you, and please register to join. Children are welcome. They will enjoy face painting, music, and many, many other things that will happen that day. We are on all social media. Please visit us. And let us know if you have any questions or have any topics you're interested in. We announce all of our programs and events on our social media sites and our website. So I want to thank everybody for joining us this evening for this important webinar. We wish you a great Labor Day. Be well, take care. Thank you and good night. And we are going to play Epson video now. Good night.
At Epson, we have an extraordinary ambition. We help people and families living with rare cholestatic liver disease so that they can do the things they love to do. Those things that make all of us special and unique.
At Ipsen, we are proud to be researching 5 rare liver conditions: PBC, PFIC, Alagille syndrome, BA, and PSC. But our research doesn't stop once a medicine is proven to address or improve an underlying condition. We must continue our efforts. We want to understand the long-term, real-world, and day-to-day impacts of our treatments so we can continue to innovate on behalf of the communities we serve.
Rare liver disease communities are not comprised of patients. They're created by people with a passion to learn and educate, people who have advocated for their care to get answers, parents that support each other while empowering their kids, and kids who are braver beyond their years. At Ipsen, this is why we listen more and talk less, letting the community experts lead the way.
We lead with our hearts and make decisions that are grounded in science.
Thank you, Epson, for your support and your grant, your educational grant. Good night.